it's as big as it's going to get. And evaluation. If you require any of this, just please follow the instructions that were given to you initially at the beginning of the presentation. Next slide, please. Disclosure, myself as the presenter, I don't have any financial arrangement related to the content of this activity. Next slide, please. The disclaimer, the views expressed in this presentation are those of the speaker and do not necessarily represent views, policies, and position of the University of New Mexico. Very important. Next slide, please. Now, in terms of the learning objectives, objective number one, I would like all the people that are here to specify cultural factors that impact mental health services in the Latino community. Objective number two would be to describe most common barriers for obtaining mental health services in the Latino community, and to describe culturally competent strategies for engaging Latino patients in mental health treatment. It looks like a tall order, and it really looks like a bit of a dry topic, but it's quite important to know what to expect when engaging someone who has not been acculturated, or even people that have been here for many years but still retain some of the structure of Latino population, specifically related to family and cultural background. Next slide, please. Now, in terms of cultural considerations and the information that I used, the populations mentioned in this presentation will include people that are born in Latin America, irrespective of their ethnic background, language, or country. Very important, when I say language, we will see how Latinos and Hispanic populations are different, and we will touch a little bit more on that. But when we're talking about Latin America and Latinos in general, that will include people from Brazil. Now, special emphasis was placed on immigrant population living in the US from 1968 to 2020. For this reason, certain populations may be under or overrepresented, because we cannot always get a correct sample of every possible Latino population, and perhaps countries that are nearer to the border will be more represented than others. The following presentation is not intended as a faithful representation of all populations, but a summary of the best available evidence about current topic. Next slide, please. Perfect. So I thought that it would be a good idea to start with an introductory case. That way we can place a name and well, not a face, but at least a name to the barriers that we encounter. This is Maria Salazar. 47-year-old female, recently moved from Chihuahua, Mexico, Spanish speaker only, and inconsistent medical care. Last time she went to the doctor was before the pandemic, and the doctor mentioned something about her blood sugar and blood pressure, but she definitely didn't follow up on that. Maria lives with her husband and 4 kids. She spent most of her time cooking and cleaning and takes care of the kids. She has been feeling unwell and lazy. Husband has been complaining about Maria not completing house chores and her cooking going, quote unquote, downhill. Maria is scared that if she does nothing, husband is going to leave her. So Maria doesn't have many friends in the United States. She's part of a church that's near her home, where one of the other parishioners recommends her to go to the UNM emergency department, but she disregards the idea because she is uninsured and is scared about the police in the hospitals. Other acquaintances recommend a cash-only doctor that helps immigrants on the other side of town. Maria makes up her mind and decides to go to the first appointment on Friday. Next slide, please. Now, let's talk about what are the main barriers for care and all the considerations that we need to have, especially for someone like Maria, who has recently come to the country. So there is definitely a discrepancy between the Latino population and use of services. So it has been postulated that socioeconomic and cultural factors are critical in Latino underutilization of services. And I can give you many demographic data about Latinos in this country. For example, I can tell you that about 17, they are about 17% of the population now in the United States, and it's the largest minority group in the US, and Latinos are only growing in the past few years. So, but I don't think that that's particularly the point. The thing that we know is that Latinos are not prone to look for services in the community for many reasons, including the fact that perhaps they don't know where the services are located. Perhaps they don't have a support system or a safety net in place, so they can rely on people to, for example, in the case of Maria, take care of children or help them with house chores or any of the obligations that they might have. There are other cultural variables that we will touch upon in a few minutes, but right now I just want to give the overall picture of a patient like Maria. Additional to this, their healthcare access is very limited by disproportionate rates and underinsurance, and the utilization of care is quite low. There are many factors that actually make healthcare difficult for Latino populations in the US. It has also been postulated that there are many more sources of stressors for recent immigrated Latinos. For example, the changes with family and the fact that they're here in the new culture. This will make Hispanos and Latinos more vulnerable to adverse mental health and other diagnoses, including depression and anxiety. We will touch a little bit more on further data about this, but there has been definitely some research about it, and new immigrants are definitely more prone to this situation. Next slide, please. Now, one critical thing that you really need to understand about Latinos in general and Hispanics in particular is that there is a lot of diversity in Latino population. So usually we try to contain and encompass the Latino experience in one single bag. But even in one country, we can have significant differences between state by state or city by city. For example, the patient that we're talking about, Maria, is coming from Chihuahua. She probably will have a completely different experience than a patient coming from the capital city, for example, the Distrito Federal. Other examples of this are people, even in the same country, having different experience if they're from the coast region, that if they're from the mountains. So they will have different outlooks in life, different ways of interpreting mental health in general. And finally, very important to know about Hispanic America. Difference between specific countries are very, very important. For example, in Argentina and Chile, in the southern portion of Latin America, they have a big cultural component related to therapy and mental health. So it's in their popular culture, it's in comics, they usually go to therapy, and they're very involved with mental health. On the other hand, the rest of Latin America, that is not the case. As I told you before, very important to know the difference between Latin America and Hispanic America. Hispanoamerica is the place that only speaks Spanish, and Latin America includes also Brazil, where Portuguese is the primary language. Also, this is a not as important distinction, but Iberoamerica relates to all the countries that were conquered at some point by the Iberic Peninsula, meaning Spain and Portugal. Next slide, please. Now, in terms of psychopathology, there has been significant controversy about how Latino populations have higher rates of depression, anxiety, and other mental health illness. So on one hand, it has been postulated that Latino populations definitely have higher rates of depression and anxiety than their Caucasian counterparts. But this notion has been disputed on other studies that show that perhaps there has been a bias while selecting population. So there might be definitely some more depression, anxiety, PTSD, increase in recently immigrated Latinos. However, when we study Latinos as a whole, it doesn't look like there is much difference. Now, the other thing that we need to take into account is that perhaps Latino populations show up less looking for services, so figures can be skewed. So there's a lot of data involving demographics about this particular topic, but there's not really a clear answer about this. It looks like Latinos genetically are not more inclined to have mental health illness, but the set of circumstances that they have to deal with, acculturation, culture shock, and many others can impact their mental health negatively. And the fact that they don't look for services as often make us not see it. And I think that that is the main point of this slide. As you can see, Caucasian populations are definitely higher than Hispanic and African American and also Asian, but take this with a grain of salt is what I'm trying to say. Next slide, please. Now, going a little bit back to Maria, probably her most standout quality is the fact that she recently immigrated to the United States in terms of mental health, I mean. So I want to talk a little bit about what culture shock is and acculturation. Depending on where you are from, life in the United States, and also where you migrate to, life here in the States can be fairly similar to what you had back home or completely opposite to what you used to experience. In terms of medical services, they are significantly different, especially in countries with universal healthcare. Waiting time, price, distance, and even relationship with the provider, or things like completing paperwork and the amount of paperwork that we need to complete here in the United States can be challenging when moving to a new country. And that would be part of the culture shock phase. So Maria is recently moved to the States, and she is definitely experiencing culture shock. Now, on the other hand, when we talk about acculturation, and it's important for me to review the concept, which is bi-directional relationship between the subject and their culture. So how the subject relates to the culture and how the culture relates to the subject. It's very interesting to think that people that have been already acculturated, for example, already speak English, they get accustomed to the culture, they're already of the culture shock and they get used to what's going on in the country. They can also experience higher rates of mental health issues because of the pressures that they experience from the society to behave a certain way, the fact that they are trying to reconcile their previous self with their new self and thinking that they are quote unquote losing their home culture, or even talking to people back home where they can tell them, well, you're not the same as you were, you don't speak the same. So it can be very difficult, especially when you're returning home. And then you get reverse culture shock with what happened in your home country and also with what you are inside, and that you're different from the time that you left to the time that you are back. So those are the key points where a person can actually experience mental health issues. Now, when they get reacquainted with home culture, or when they come back to the new home and they come back to the new culture, they get a little bit more stability and they perhaps can get better. Next slide, please. So going back again to Maria, she really wants to do something about her problem, but for many reasons, she hesitates. And for one, she doesn't know what's going on with her. And this shows very low literacy in terms of mental health issues. And this can be very common in specific Hispanic and Latino populations, especially from rural settings. Additionally, there's a tendency for Latinos to underutilize mental health services, primarily in the community. It has been said that a lack of knowledge of available services, low disponibility in different neighborhoods, and other cultural considerations, they might play a role in that. And we will discuss the barriers of care in a second. The importance of this slide is to show you that even in communities that have less access to mental health care, white communities still have higher providers per 10,000 people than Hispanic or African American communities. So as you can see here, 8.6 providers in Caucasian communities versus 5 and 5.7 in Hispanic and Black. And the difference become a little bit more pronounced in communities that have a higher rate of mental health provider, with Caucasian communities having 9 and 6 and 6.6 for Black and Hispanic communities respectively. Which means that even with in communities that have very high number of providers, it's very difficult to find the same level of care and number of providers if your community is primarily Hispanic. And as we are well aware, usually Hispanics and Latinos tend to move to those communities because they feel protected, because they feel less persecuted, because they have some sort of support net in terms of their neighbors. Next slide, please. Now, the second part of the case, Maria has to leave her children with her friend from church. She goes to the doctor and she arrives at the doctor after taking 2 buses and walking for about a mile. She waits for about 2 hours to be seen. Dr. X, who is a PCP, recommends follow-up in a couple of weeks about her blood sugar. Additionally, the doctor diagnosed MDD first episode and recommends talking to a counselor. He hands out a list of available therapists in the area, and the provider mentions that the waiting lists are a little bit long, and because Maria is uninsured and Spanish speaker only, this makes it difficult for her to get a therapist. PCP also suggests to start an SSRI and discuss multiple options with Maria. The patient is ambivalent about this and says to the doctor that she will consult with her husband. Maria has to run to the bus stop and almost misses the last bus back home. Next slide, please. So as you can see, Maria has many barriers to her care. The first one is definitely economic. So Maria is a recent immigrant from a family that is large with a sole source of income. So we're not sure about the patient and husband's legal status, but according to demographic data, there's a high likelihood for patient husband having a service position that would not be highly remunerated. So because of immigration status and because they're new to the country and perhaps they hadn't had the chance to get an ITIN or Social Security, depending on their legal status, they are less likely to have employer-sponsored healthcare, as you can see in the first part of the slide. Also, they're more prone to be poor, which is very interesting and quite sad. So research has shown that recent immigrants and Latinos are especially at risk for poverty. So most of recent immigrants have little to no access to insurance. They usually seek free services or in community services or in community centers, I'm sorry. Unemployment rates in Latino females are definitely higher compared to Latino males and other females in general. And there's a high fertility prevalence for Latino females. All of this means that even for Latinos who are aware and are able to look for services, socioeconomic factors might preclude them from accessing them. That's especially relevant for Latinos in general, but females in particular, and also children, because parents having a very low healthcare literacy in terms of mental health, make children wait more time and look for services later in their life. Next slide, please. Now, a little bit of a controversial topic, and I just want to remind you that this is not a rule for all Latinos, but more of a risk factor situation. So in terms of, from a cultural standpoint, some Latinos have more of a collectivistic mindset, and goals that they have are usually focused on benefiting the family rather than the individual. And that has a lot of correlation with something that is called fatalism, that in some cultures, in Latinos specifically, people believe that there is no point in trying to control your luck or your circumstances, that you have been dealt with a set of circumstances and that you cannot do anything about this. So in this particular topic, I think that Maria is a great example. So Maria doesn't see a lot of benefit in taking care of herself. The only reason that she looks for help is not because she really wants to do it for herself, but because she's scared about the consequences if she doesn't. She's scared about husband leaving her and probably children having to go with her back home. So it's a really interesting topic to discuss. And Latinos usually suffer from what I call a dominated mindset, with individuals most times being content with their current work position, not aspiring for higher careers, and with a fear to speak up because they really fear the police and repercussions and alerting authorities or being persecuted. And this is why I included this slide, because the family is really the center of the social structure. Families are extremely traditional. Father is the head of authority and the main decision maker. Mothers are definitely part of the picture and revered as the head of the household, but the role is secondary to their husband. And Latinos consider their duty and responsibility to help all family members, not only the immediate family, but also the extended family, even the family that it's back home. Extended family is as important as the nuclear family, since it provides a sense of stability and the main safety net against mental health issues. Next slide, please. Now, going back to Maria, she doesn't own a car, definitely not familiar with the city, unsure how to connect with providers. And if you've been around Albuquerque recently and many other cities in the States, transportation is very difficult. Public transportation, I mean, is very, very difficult and completely different to what they could have experienced in their hometown. This signifies an almost unsurmountable barrier. As we could see with Maria, she needed 2 buses and then she almost missed the bus back home. Also, it take her a long, long time to get to the provider. And then on top of that, she needs to wait some more time to see the provider. So in terms of a time consumption, Maria requires anywhere between 3 and 4 hours to go to the doctor. And the feasibility of doing that every week, for example, for counseling, it's definitely not the best plan and probably not feasible for her. It has been shown that low-income neighborhoods where Latinos tend to live have very low accessibility for services, as we showed in a previous slide. And if they exist, they usually provide lower quality of care. Now, next slide, please. And this is the last portion of the case. So after a few months, Maria can get connected with a therapist who is not fluent in Spanish, but can communicate with Spanish speakers adequately. Maria takes an intake appointment. She is nervous and does not know what to expect. After 3 sessions, Maria feels disappointed as the therapist keeps asking unrelated questions to Maria's concerns and does not provide a solution to her problems. The patient feels that she does not have money to waste and stops going to therapy. This is fairly common on our Latino populations, and we will explore a little bit why in a second. Next slide, please. Now, even though Maria is able to get a therapy session, which is almost miraculous in this setting, and knowing that Spanish speaker providers are few and far between, it takes her a while to do so. So it has been shown that treatment centers usually do have a preference in terms of socioeconomic factors to see patients. And this is not only for therapy or hospital-based setting, it's just in general. And that's why I wanted to include this specific slide. As you can see, and specifically to women, the socioeconomic factors are big in terms of the preference that specific treatment centers might have to patients. So a higher rate of females from high economic background are being seen in therapy centers in comparison to 1.9 and 2.1% from low and middle, and also that also is corrected by age, where the difference is even higher. So what this means is that there might be a little bit of a bias in providers as well, because Latino populations tend to have a different outlook about their treatment. They want different things, and perhaps the intake and assessment experiences become awkward, and they are not getting the answers that they're looking for. So they decide to stop coming. And if they're from a lower socioeconomic strata, um, perhaps providers can get a false sense of, well, Latino populations don't want to engage in certain therapeutic settings, so maybe I shouldn't be taking as many Latino patients. If I can take other patients that would be more engaged and would like to come to services more, that would be more beneficial to them versus having a patient for 2 or 3 sessions and then discontinuing the treatment. Next slide, please. Now, speaking about cultural variables, multiple notions influence perception and access to mental health. First, patients tend to give higher importance to somatic symptoms and misinterpret symptoms of depression or anxiety as a somatic illness. And the first person that they usually see is a PCP. So this is very important for our case. If you remember, Maria didn't complain about poor sleep, energy, concentration. She specifically said, I'm feeling quote unquote lazy, and she gave a high value to her blood pressure and sugar concerns, because she is making a decision, a conscious decision. Well, what problems do I need to address so I can move forward and keep on living, versus what I can do to better myself and be a better mom or a better partner, or to feel better myself. So another big consideration is that going to a PCP will avoid the patient the embarrassment, quote unquote, of being seen by a mental health provider. There is a lot of stigma about mental health in the Latino community. Other couple of things that we really need to consider are fatalistic views of life, which we have discussed a little bit before. Also, in some studies, patients with very high religious beliefs have been linked with delayed efforts to seek mental health. This might be explained by the fact that the church becomes their community, and they much rather spend time and try to figure their problems out with church members and parishioners and church leaders instead of looking for care. Another big part of this is familism, which is quite important in the Latino culture, where subjects are really happy to get family support and use it as a therapeutic intervention. Patients tend to be secretive about familial affairs and prefer not to disclose mental health problems, as they perceive it as a sign of weakness. Another component to consider is that once family safety net is no longer present for patients, there's a high likelihood of mental health illness ensuing. The family portion of this situation is maybe the most important one in the Latino population. So not only back home in Latin America, but also here in Latino populations that live here in the States, in remote parts of this city or in the state, still feel that it's embarrassing for family members to have serious mental health issues. And for example, we can find schizophrenic, untreated patients that are hidden to society and that have never been seen by a provider because they don't want to show their neighbors, or they don't want to show society that mental health, that there's a crazy person in the family.
Dr. David, you are muted.
I do apologize. For some reason, my computer just disconnected.
Okay.
As I was saying, definitely that's a main consideration in using the family and the community as a tool might be a way to prevent things like this from happening and Latinos to access mental health care. Next slide, please. Other considerations also include language issues, language proficiency issues, not only to access mental health care, but we don't always stop and consider how important is language in our day-to-day lives. So to interact with your community, to have a conversation with your neighbor, to go to the bus stop and understand where you're going and how to ride the place that you want to go and where to leave the bus and go to your appointment. So it's very important, and it can be detrimental for mental health care and also to life in general. And it can be very stressful to not be proficient in English. Also, it can be detrimental to the number of services that the patient is able to receive, because most of the providers are English speakers only. So that takes away many options that patients might have. Now, when discussing client therapy interaction, there are multiple considerations to be had, ranging from the patient preference for the provider ethnic background. So it appears that most patients with low acculturation rates prefer a therapist with the same ethnic background. By contrast, patients with a higher level of acculturation appear to be okay with any clinician. This is quite an interesting topic, because there has been a couple of studies that show that actually acculturated patients prefer a therapist or a provider that is not from the same culture as them, because they fear to be categorized as the prototypical Latino patient, and when they are acculturated to the country, they wish to be treated more like a citizen of the world instead of an immigrant Latino. Other issues that we encounter is provider bias secondary to negative experience with Latino patients in the past, and stereotyping patients by their ethnicity. All of these factors impact outcomes and determine the time that patient uses services for. Additionally, the lack of standardized translated tools for assessment, limited patient experience with mental health, and lack of culturally sensitive ways to administer the test, and patient preference for different therapeutic approaches lead to odd assessment experiences that contribute to discontinuation of services. As I told you before, not all Latinos are the same, but in general, there's a lot of paternalism still in Latin America related to health. So usually the patient goes to the doctor seeking an answer. And when they go to the doctors don't usually discuss therapeutic options or interventions so the patient can choose from. So when a therapist or a provider or anyone involved in mental health has a conversation with a patient about options, from usually patients feel out of place and they don't know what's going on. So they might come to therapy or to a psychiatrist looking for a specific answer. You should do this, you should do that. And managing expectation ends up being a very important portion of the whole situation. Now, if you were able to see the previous slide, I understand that the presentation is no longer there, you could see the patient preference of a therapist according to their ethnic background. And there's not an insignificant portion of Latinos that prefers someone that is from their same ethnic background, around 33%. This can be corrected by newly immigrants to about 50 or 55%. Well, now, let me try and share my screen because I can no longer see the presentation, and I'm sure that I can do that. If you give me just 1 second. Yeah, I do apologize about that. We just a second, and anyway, in the meantime, moving forward, now that we have had the time to discuss all of these considerations and to actually know a little bit better what Latinos experience on a day-to-day basis, I wanted to discuss finally what to do next and how can we be of service to the community. So I did kind of a top 9 possible alternatives to barriers and cultural considerations of care. Number 1, more services in more diverse areas. So focus on flexible scheduling early in the day, later at night, during weekends, and providing additional education to how to identify mental health illness and where to access services is going to be crucial. Also, we need to highlight financial aid or free services whenever possible and accessible transportation for our patients. Thank you. And that'll be the next slide, please. Now, number 2 is awareness in mental health practitioners. Having an open mind, talking to each patient as they come, and not stereotyping patients is a fantastic approach. Always having additional knowledge about cultural differences and challenges is quite helpful. Multicultural education programs and workshops should include information about religion, the importance of family, and different approaches to therapy. The challenges of acculturation, solution-focused approaches is very important. So how to help the patient figure out what is the best possible solution without making them feel that they are doing all the work, and incorporating family in the mix as well. So when in doubt, ask the patient what they feel comfortable with and what's the best approach for them. The more exposition that we can have to cultural diverse patients, the better competencies we will develop. Number 3, and this is key, consider religious leaders and PCPs as allies. So sometimes we don't see as many patients as we wish because they are not able to reach us. If we are able to provide information to PCPs and religious leaders with all wraparound services, ancillary services, and providers that are Spanish speakers or fluent in Spanish, that might be the best way to engage the community. Number 4, improving verbal communication. Training more bilingual and culturally competent staff, including interpreters, social workers, and physicians. Don't hesitate in using an interpreter if you feel that the patient is more comfortable communicating in a different language. It doesn't have to be Spanish only. If you have a sense that a patient that doesn't feel comfortable talking in English, or they cannot express themselves adequately, you can always use an interpreter. And that's a very important distinction, because even though for someone like me that I'm able to express myself in a good way in English, my emotional language end up being Spanish. So if I had a choice, I would do services in Spanish, because it's easier for me to express feelings that way. Number 5, using only validated assessment tools in patients' native language, and communicating with providers that are more familiar with these tools might be quite helpful. So try to use the tools in the language that we are talking to patients. Next slide, please. Improve treatment adherence by communicating, managing expectations, and making sure financial factors are not impacting care. So be transparent with patients, asking them what's going on. You can tell me this is a safe place. And also making sure that they're able to pay for services. I understand that some patients don't have the financial literacy to know that perhaps they can be enrolled in Medicaid or Medicare, or that some services would not cost them as much as they think, or knowing that there are coupons available, or there are different options. Talking about all these things during consult or during any therapeutic interventions. Number 7, use a culture-centered approach if and when possible. Number 8, attempt to provide psych education to debunk paradigms about mental health. Very important. This is very prevalent in the Latino community. Talking about being crazy. I don't want to be cataloged as crazy. People around me will tell me that I'm insane. I don't want people knowing this or that. Giving examples about other community members, or giving examples about popular culture where there are positive examples that use mental health services and that are benefited by them would be really good. And number 9 and last, community-based approaches where multiple providers are involved resemble family structure and are ideal. So everything is family-centered, and Latino populations really need to feel protected by their inner circle. So if possible, having a community-based approach, it'll be the best way. Next slide, please. And those are my references. I really appreciate your time. If you have any questions, please let me know.